Hi, this is Brian Kim, and I'd like to share with you the double chop technique and how I feel it's helpful for weak zonular cases. There was a Phaco Fun webinar that I participated in about weak zonular cases, and so we talked about how the zonules are like the springs of a trampoline, and of course if the springs of the trampoline are very weak, it's unstable and the mesh will not be stable and rigid. Thus, you can imagine if the same goes for the capsular bag, the posterior capsule can fly up anteriorly towards the phaco needle and cause damage. And so this is a principle in the analogy that I always think of, that weak springed trampoline. And so as you see, I'm trying to puncture with my capsulorhexis forceps and I'm not able to, and that's because there's such zonular laxity that when I push down, the zonules give way and the capsular bag, the anterior capsule, just pushes backward. And I use the analogy of trying to bob for apples with Vaseline on your fingertips. You just aren't able to grab that capsule. And so even when I'm able to grab it, you can see I'm not able to puncture at all, again, because of the weak zonules. And so I went ahead and switched to a sharp cystotome needle to puncture and pull and create that rhexis opening. And then I switch back to my capsulorhexis forceps. And as I begin the capsulotomy, you'll notice some capsular stria on the capsulorhexis at the 2 o'clock position. And that's because the zonules are so weak. As I'm pulling the flap, there is not enough zonular counterforce to hold that capsulorhexis tight, that it causes that anterior capsulotomy area to have a little bit of a fold or stria. So I'm going to finish the capsulorhexis, which was otherwise uneventful, and then I'm going to proceed with hydrodissection. I do a one-step hydrodissection technique, and you want to push the cannula tip into the equator, and when you do so, you get a consistent and gentle hydrodissection wave without any difficulty. Sculpting techniques are limited with weak zonules because sculpting relies upon the lens material to be supported so that while you push down on the lens material that you're able to sculpt. But with weak zonules, you can't depend upon that because the lens tends to give way because of the weak springs. And so the double chop technique is much better in this case. Now, as I begin to do my phaco, and this is a new Kim double chopper made by Katina, I have no financial interest except for just designing the instrument for them. You can see there, as I was removing the epinuclear material, there was significant jiggling of the bag. And again, that's another sign that there's significant zonular disease. So it's helpful to remove that epinuclear material, because as you do that, if you see that jiggling of the bag, again, it just validates the weak zonules. So I take the chopper out to the equator, I put the phaco tip deep into the subincisional lens material, and I bring the instruments together and I perform the double chop. I take the chopper out to the contralateral equator and I perform the cross chop maneuver. I'm able to segment the lens into 3 pieces within a matter of seconds without using ultrasound or vacuum. And this is a very zonular friendly approach because all the forces are directed centrally. And so now I'm trying to remove and fracture each of these lens pieces. As you can see, because the zonules are weak, the fragments are just somewhat stubborn and they don't want to come out. And again, that's because the bag is so floppy. As you pull the fragments, it is somewhat sticky and it causes the capsular bag to come with it. And so now this right lower quadrant is going to be a little bit of a challenge because there's a little bit of an angle, and it really doesn't want to come out because this is very sticky. One thing you could do in these cases is go back and try to hydrodissect. Now that you have more space, that would actually work pretty well, and that would cause that lens to prolapse to the middle. But instead what I do is try to use my chopper to just prolapse that little quadrant to the middle, and I'm just trying to do this very gently. You can see how much that bag is moving, and so I try not to perseverate too much. I go ahead and just real gently try to tease that up, and then I go ahead and activate the vacuum to help me get that lens fragment up, and then I go ahead and try to chop it gently. So in these cases, it is helpful to activate a little bit of vacuum and suction. Here, I don't rotate that
heminucleus, it's not even worth trying. You'll just strip more zonules. So I just grab it with some vacuum, prolap, I pull it towards the center, and then I chop that fragment. Again, take the chopper out to the equator and place that phaco tip deep. And when you're able to do that, you're going to ensure that you get a consistent chop.
Double chop technique is better than traditional approaches because it doesn't rely upon vacuum to grab lens material. In these cases with weak zonules, if you grab the lens material deep in the bag and you don't have occlusion to hold the lens material, it might cause the posterior capsule to come forward and be ruptured. Whereas with double chop, you use only irrigation and you basically sandwich the lens materials between the chopper and the phaco tip. You can place that phaco tip very deep in the bag with confidence and fracture the lens consistently. Whereas if I was trying to do that with a traditional phaco technique, I would use vacuum to grab the lens material, and that can cause posterior capsule rupture. In rare cases in the past, when I did the traditional phaco chop technique in dense lenses with weak zonules, after I removed the lens material, I noticed that there'd be a hole in the posterior capsule. And I would wonder why that would be, and I think it's because of this problem, is you don't want to use vacuum in these cases because of the floppy posterior capsule, whereas double chop, you don't have this issue. And again, that's because you're mechanically fracturing the lens by using leverage to sandwich the lens material between the chopper and the phaco tip without any vacuum, which makes this a much more controlled and safe approach.
So at this point, after I remove the cortex, which I remove in a tangential side-to-side sweeping motion like I'm doing here with this sweep, don't pull centrally because you'll isolate the zonules and cause more zonular stress. You want to sweep side to side in a tangential manner, and that helps minimize that zonular stress. You also like to clean up the lens epithelial cells because this helps minimize capsular phimosis, which is a concern with these weak zonular cases. I also like to use my INA tip after the lens is in and just sweep a little bit more because sometimes I see some more lens epithelial cells as I'm cleaning underneath the anterior capsular surface. You can see I have a very good and consistently round capsulorhexis overlap over this optic, and that's because I use a corneal marker to help guide me as I do the capsulorhexis. Here I try to remove some subincisional lens epithelial cells and I grab the capsule. And so thankfully this polymer tip is very capsule safe. I recommend it and use it on all my cases. And so I'm able to disengage the capsule without causing any damage. And so it made me think perhaps I should have put in a 3-piece lens instead of this 1-piece lens with these weak zonular cases. The 3-piece lens would be better for future fixation. And as I'm INAing, you can see the lens is wobbling considerably. And I remove my INA tip, and when I do that, I like to keep the chamber stable with the BSS cannula. And as I did that, you can see that lens is really unstable and was moving purely with the BSS fluid being pushed through the cannula. So I paused and I said, okay, maybe in this early 60-year-old gentleman, I really need to do better than that. And so I decided to put in a capsular tension ring. I went ahead and filled the bag with some viscoelastic, making sure it's completely filled so that there's no folds in the capsular fornix. I like to place the CTR into the injector myself because in the past I had times where I injected the CTR in the bag and then it became disinserted from the injector. And so I'm going to go ahead and place the CTR in the eye, and I'm going to use the Sinskey hook to engage that leading eyelet. And as I advance the plunger of the injector of the CTR goes into the bag, but I'm using that Sinskey to hold that leading eyelet to maintain and minimize any rotational forces on the zonules. Although it disengaged a little early, that was okay. Most of the CTR was already injected. I'm making sure the left haptic is not incarcerated by the CTR. Not quite clear the status of the right haptic, and so I'm going to go ahead and use a Sinskey through the paracentesis to get a better angle. And thankfully, the CTR is not incarcerated by the haptic. And then you want to remove the viscoelastic. I always like to go underneath the lens. Make sure that as you tilt, you're tilting on the long axis where the haptics are so that you make sure that the haptics are in the bag.
So this is a test. Last time when I put BSS in the cannula at the end, you saw significant jiggling. Now I'm going to remove the INA tip and I'm pushing BSS in the eye, and there is no jiggling at all. And so you can see there's much more stability. So remember, small pupils unresponsive to epi, worry about weak zonules, but not just small pupils, but large pupils like this case. When you put OVD into the bag, look for significant deepening. That occurs because the zonules are so weak, just like the weak springs of a trampoline, and the mesh is just saggy. Same thing with the capsular bag, it's very saggy and the lens moves backward. Look for stria during capsule puncture and during rhexis formation. Try evacuating the surface epinuclear material, and when you do so, if you see significant phacokinesis, this is also another sign. Try using a technique that minimizes zonular stress, just like the double chop and cross chop. Remember, sculpting relies on pushing on the lens material and requires that counterforce of the zonules to hold it up. When you don't have that counterforce, that's a problem. With phaco chop, you have to rely on high vacuum to hold the lens material. High vacuum means that the posterior capsule can come forward because the zonules are not tight enough to keep that posterior capsule back. Never activate vacuum except when you're at the iris plane, and pulse the phaco very gently, again for the same reasons. During last quadrant removal, hold the chopper deep in the bag and keep the phaco tip up anteriorly and pulse the lens material. And if necessary, fill the bag with viscoelastic to keep the posterior capsule back. Gentle cortical cleanup with tangential forces, not central stripping forces, and consider a capsular support system when necessary. I hope this was helpful for you. Thank you for your attention.